So vulvodynia is a type of vulval pain syndrome. The other one being something called vaginismus, which is the involuntary tensing of the vaginal muscles when something is inserted into the vagina. Vulvodynia is a bit different in that it's pain usually on the outside of the vagina or vulva, and it has to have gone on for more than 3 months and have no other causes that have been established. So it's a diagnosis of exclusion. I think that's the official diagnosis. I think often it's much more not clear cut in clinical practice. Often women have many years of histories being told they have things like recurrent thrush or UTIs and have tried various treatments with various responses. For example, sometimes, if someone has been told they have thrush and they're putting thrush cream on, that's quite soothing and it could give you a perceived improvement in symptoms, but actually it's not that they have that other condition. It's relatively common. I think it's under-recognized by many clinicians. I think the evidence suggests a lifetime prevalence of about 16%, and it can occur in all women of all ages, but we see most cases in younger women. I think the thing to say is that patients often don't present telling you they have pain or vulvodynia. They describe other sensations that they may come in and say, I have thrush, it keeps coming on, I have irritation in my vagina, I have itching or burning. And I think the key also is in the history. Because they will often say things like, oh, I don't use tampons because they cause me irritation, or pads give me thrush. I don't like riding a bike because it just makes me feel uncomfortable. They also often will say that sex can be painful. They don't enjoy sex, and that can be difficult for them and their partners to try and understand why. There's lots of causes. It's multifactorial, which often means that we never know exactly what's caused it. I think sometimes there's absolutely no history and it just comes one day, everything's fine, and the next day it's not. I find that usually there's some sort of precipitant, whether that be it was a really bad episode of thrush and then since then they've had problems, or they've had other conditions around the vulva, dermatological conditions, for example, like lichen sclerosis, where they've had ongoing problems, and then whilst that's controlled, the pain and irritation still happens. It's important just to recognise that there may not be a specific cause, but it is a condition in its own right, and women need to know that and have their sort of fears and worries allayed, that this isn't all in their mind, which sometimes they have been told. History is key. This is about sitting down and spending time with a woman and understanding when her symptoms started, what's been told to her, what she's tried, what makes things better, what makes things worse, and what can she enjoy and what can't she enjoy. That really, really helps you to get a feeling as to vulvodynia may be the underlying cause. But because it's a diagnosis of exclusion, we also need to rule out all the other causes. So obviously a detailed examination by someone who's experienced, looking at the vulva itself and checking that there's no dermatological conditions, ruling out infections. So things like thrush and STIs and bacterial vaginosis, we test for all of those just so that we can reassure the woman there's no ongoing infection that they're carrying, which again has been told to them by certain clinicians over the years sometimes. And we use a Q-tip or an ear stick to touch areas on the vulva to try and ascertain whether the woman has altered sensation, because it may not be pain they experience, it may be a heightened sensation from one side compared to the other. So sort of mapping that out and checking if they have things like vaginismus, that involuntary tightening of the vagina, which can go, they can go together, and they can be, it's not kind of you have one or the other. There's often an overlap. So that's kind of the history and the examination, and ruling out other causes is the crux of the diagnosis, basically. I think the first thing to do is to reassure women that this is a recognized condition. It's not a psychological condition, and they're not harboring a chronic infection. And I think understanding this themselves and also ensuring their partner, if they have one, understands it is really, really important. There's also things that they can practically do. So they can read about it, understand other women's journeys and things they've tried. They can just make sure that they're employing good vulval care, so washing with an emollient rather than things like Femfresh, which cause loads of irritation to women, and making sure they're not triggering things, so avoiding tight synthetic underwear and just wearing cotton and non-irritating underwear can be really, really helpful. I tend to start my treatment pathway whereby it's about information and good vulval care. And I often give some topical treatment to start with, which has got some local anaesthetic in it, to give women a chance to try that at home and see if they can get relief from their symptoms by dampening down the nerve fibres sort of sensation by using this local anaesthetic. And that can be all they need sometimes, but often they will come back and say, yeah, it did help a little bit, or no, it caused me irritation, so I couldn't use it. There are also oral medications that we do use to help women. One of the most common is something called a tricyclic antidepressant, something like amitriptyline. And this is used in lots of neuropathic pain conditions. So it's not used as an antidepressant very often anymore. So it's used in lots of pain conditions, and they can be really helpful for their analgesic, but also their anti-anxiety effects, and can really improve symptoms for women. There are other medications that we can use if these aren't tolerable for patients, or if they can't take them for other medical reasons. Sometimes we refer them or their partner and together to psychosexual medicine, so they can try and learn to enjoy sex again, and as we kind of work on the other side, the medical side, to improve their symptoms. We also sometimes refer them to the gynecological physiotherapists who can help them to control their pelvic floor, which again can sometimes help. There are surgical procedures that are documented. I've never needed to refer women for those sort of procedures. It's very variable in women, and I think it's really important to give them a realistic but positive outlook. Most women can over time get over this completely. Some people it does come back, but I think the key is recognizing that, because when you first see them, they've had often years of undiagnosed pain in that area, so it can sometimes take longer to treat the first instance, but if it comes back instantly, they recognize the symptoms and can quickly get back to the treatment that they needed and control it much better. I think it will, in the vast majority, 90% of women, subside over time. There is a small cohort of women, about 10% is documented, who do have ongoing symptoms, but again, that's the minority of people. So I think it's really important to say there is treatment, there's a positive outlook, and we can help you.